In continuation with our series on breast health and breast cancer, I'm delighted today to welcome in India Dr. Nicola Rocco, MD PhD, a leading voice in modern breast cancer surgery in Italy and all over the world. Dr. Rocco is a breast surgical oncologist and assistant professor at the University of Naples, Federico, in Italy, and previously served as chief of breast surgical unit at the Malzoni Cancer Center. With advanced training in oncoplastic and reconstructive breast surgery across Italy and a PhD in advanced biomedical and surgical therapies, studying the potential applications of 3D printing and regenerative medicine in the field of breast reconstruction, his work sits in the cutting edge of innovation and patient-centered care. He is a scientific director at Greta and Bresco certified breast surgical oncologist and like a surgical editor for the Cochrane Breast Cancer Group, contributing to global evidence-based practice. He has authored over 100 peer-reviewed publications and plays an active role in European oncology education. We are thrilled today to have Dr. Rocco with us today to discuss breast conservation versus mastectomy, making confident evidence-based choices. Hello, Dr. Rocco. It's just wonderful, Nicola, to have you with us today in India. And I look forward to a discussion which will be very informative, not only to the medical community, but to the women of India and the families where they have choices to make when they're detected with breast cancer.
Hello. It's my pleasure to be here in Pune. And it's my pleasure to receive the invitation from the Prashanti Cancer Mission. And thank you for your really kind and extensive introduction. So I will be happy to discuss, and I would be also pleased that if our discussion will be useful for all Indian women.
Yes, I'm sure it will be a very insightful, and it will be a great advantage for the women to hear from you. So starting our interview, Dr. Nicola, I was just wondering, many women feel, in India especially, that removing the entire breast is the safest option. And is it always still true today? And do you find that also in Italy, that many women feel removing the breast is the safest option?
Well, this is a very, very relevant question, because this misconception is also present in Italy and in Europe as well. Well, we know that from historical studies from Professor Veronesi, Professor Fischer, that mastectomy is totally equivalent to breast conserving surgery and radiotherapy. So there is not an increased risk of dying of breast cancer if you undergo a less invasive surgical technique like breast conserving surgery. And we now know from recent evidence that these two techniques are not only equal in terms of overall survival, but probably, even if from retrospective studies, probably breast conserving surgery, radiotherapy could even give an advantage in terms of overall survival. So every woman should have clear in her mind that undergoing mastectomy does not add any advantage, any oncological advantage.
Thank you so much for enlightening the audience, because it's a misconception very often in India that if you remove the breast, the cancer is gone. So the patients sometimes come and they don't need to remove the breast, just have a simple lumpectomy and the breast is conserved. But they insist on removing the breast. So this is a myth, which is kind of widespread in the country, and I'm very happy that you enlightened the women on that. Further going on to this, do survival outcomes compare between breast conservation and mastectomy in a very simple term for the layperson? Is there a difference in survival terms?
There are no overall survival, no survival outcomes differences between breast conserving surgery and radiotherapy and mastectomy. And as I already said, even new evidence report that even breast conserving surgery could be better in terms of overall survival when compared to mastectomy. Well, we do not exactly know why this could be possible, but it should be very clear to our women. Undergoing breast conserving surgery could even be better than mastectomy, obviously when breast conserving surgery could be easily and safely performed.
Thank you so much. Thank you, Dr. Nicola. Dr. Nicola, what is the role of radiation? What role does radiation play after breast conservation surgery, and why is it so important?
Yes, radiation therapy plays a very relevant role in the treatment of breast cancer, both after breast conserving surgery and even in some patients who underwent mastectomy. There are some areas, some conditions in which also after mastectomy, post-mastectomy radiotherapy should be performed, both on the chest wall and on regional nodes. Anyway, after breast conserving surgery, radiotherapy should be always performed. There are some evidence in some specific cases that over the age of 65, you could spare women from radiation therapy after breast conserving surgery. But at the moment, what I said before, that these two techniques are equivalent, is when breast conserving surgery is associated to radiotherapy. And another important thing, nowadays, we are de-escalating, reducing the surgical aggressiveness, and this should not translate in an escalation of radiotherapy. We should always balance the two things.
Yeah, the new thing is less is more.
Less is more, but in a proper way.
In a scientific way,
which
benefits the patient.
Evidence-based way.
Absolutely, absolutely.
Yeah.
And also there is any recurrence rates difference between the two approaches, between conservation and mastectomy, and if that is so, or is this a common misconception among people?
Well, this is another relevant point, because in the historical trials by Umberto Veronesi and Bernard Fischer, there was indeed a difference in terms of local regional recurrences after breast conserving surgery and radiotherapy and mastectomy. But if we look at the current rates of local regional recurrence after breast conserving surgery, they are so low that they are very, very close to the recurrence rate after mastectomy because of the new systemic treatments we have.
Right.
We know how, for example, for HER2 positive patients, breast cancer, we completely changed the world with the trastuzumab, with those new drugs.
Yes.
So probably the evidence we had in the past from the historical trials of different local regional recurrence rates are no more true actually.
That's interesting.
Yeah.
It's very interesting. And in what situations is mastectomy generally needed or required nowadays today? And is it very common now to have mastectomy? From the surgeon's point of view.
Yes, this is another very relevant point. In Italy, this is an indicator of quality of a hospital, a breast cancer unit, the rate of breast conserving surgery compared to mastectomy rates. I can tell you that in my hospital, we have around an 85% of breast conserving surgery. There is, at the moment, I can tell you that there is not an absolute indication for mastectomy. Probably it's also a matter of shared decision making. You should properly inform the patient. Patients should be involved in the choice, and they should be properly informed about the different outcomes of breast conserving surgery and mastectomy. And this proper shared decision making should be based on evidence and not on personal opinions from the part of the surgeon. So nowadays, mastectomy, I can tell you that mastectomy could be considered only for very large areas of DCIS, even if we can know that thanks to oncoplastic breast conserving surgery, we can also reshape breast in which we remove a large part of the breast. So there is the other area of high-risk patients with their BRCA carriers,
Yes.
for example. In this case, we knew in the past that even if a patient was a BRCA carrier, breast conserving surgery and mastectomy were equivalent in terms of overall survival, even if breast conserving surgery was associated to a higher number, probably of new primaries, more than recurrences. At the moment, we have a very recent evidence published by Matteo Lambertini, a medical oncologist from Italy, showing that probably mastectomy could have an overall survival advantage in women under the age of 40. So in BRCA mutated patients under the age of 40, probably I would suggest to undergo a mastectomy.
In India, we very often find that a patient, who's in their 50s and 60s, when they come, they are told by general surgeons. There are many general surgeons in India who practice breast surgery, and there are few dedicated breast surgeons. And they are told that, because they don't know better, the surgeons don't know better, they're not trained, they say it's just a mastectomy. And then when you counsel them and tell them you just need a lumpectomy and not a mastectomy, sometimes it's very hard for them to accept. they come with the misconception that, if I remove my breast, the cancer is all gone, everything is gone, which is not true. And we try to explain that to them. So this is a myth.
Sorry to
Yes,
interrupt you. This is our task as oncoplastic breast surgeon and breast surgical oncologist, to transfer to the women we are going to treat that mastectomy is not the only choice, and most of all, it's probably not the best choice in many cases.
True, very true. Very true.
Yeah.
And Dr. Nicola, how has oncoplastic surgery changed what is possible with breast conservation?
Yes, this is a very relevant point because, well, we know, and during this course we went deep into several breast conserving surgery techniques in terms of oncoplastic breast conserving surgery, and nowadays we are more and more using chest wall perforator flaps, but also therapeutic mammoplasties. That is the use of techniques mutuated from aesthetic surgery in order to have a good aesthetic results, to remove also large areas of the breast and having good oncological and aesthetic outcomes. So yes, oncoplastic breast conserving surgery completely changed the panorama, the scenario, in the way that you can use oncoplastic breast surgery instead of undergoing a mastectomy. And we know that we have evidence from, for example, the ANTHEM study from the University of Bristol, that breast conserving surgery, therapeutic mammoplasties and chest wall perforator flaps are associated to reduced complication rate when compared to mastectomy, and implant-based reconstruction are associated with a better quality of life when compared to implant-based reconstruction. So it should be our first choice.
And also it's all about the quality of life of the patient later, because the psychological, the social, the physiological, the sexual outcomes, and also about her not being depressed, and now the survival rates are also better, right?
Yeah. This is a published evidence.
Initially the woman hears that she has a cancer and she just wants to get rid of the breast. She doesn't think about what happens later. But later on she gets depressed. There's, so many other issues, back issues, other physiological issues, emotional issues when she loses her breast.
There are many emotional implications related to the removal of a breast that could be easily preserved thanks to oncoplastic conserving surgery.
So I think it's very important for a woman when she's detected with breast cancer to meet a breast specialist, not to go to a general surgeon, and also to discuss this openly with her surgeon, the pros and cons, how personalized her treatment can be, and what is the way forward for her.
Absolutely. Breast cancer surgeon should be dedicated surgeon having a specific training in breast cancer treatment.
Yes.
General surgeons often think that breast surgery could be easily performed. This could be even true from a technical point of view. I'm not talking about complex oncoplastic procedures, but the breast surgeon should have clear in his mind many oncological considerations that probably the general surgeon do not have.
Yes, they do not have, and the experience is also not that much, because then they're doing everything, right?
Yeah.
And they're not specifically dedicated to breast, and the team is also not breast specific.
This is why you mentioned Brezo in my curriculum.
Yes.
And this is why in Europe we are trying to have this general certification in breast surgical oncology, in which we consider not only practical skills, but only medical oncology skills, pathological skills, radiation oncology skills, because the breast surgeon should have a clear view at 360
Absolutely,
degrees.
like a MDT approach, kind of a tumor board approach with everyone.
Absolutely.
Dr. Nicola, what are the emotional or psychological benefits women often report after breast conservation? Like normally a woman who's had a breast conservation, do you find post her surgery there are some benefits she has emotionally or physically, and have you ever heard her discuss that with you?
Absolutely.
If you touch upon that.
There are clear advantages and demonstrated advantages in terms of quality of life. You obviously have a natural feeling breast. You have a breast that could preserve the sensitivity.
Yes.
Even if we are talking about also nipple sparing mastectomy and immediate reconstruction, anyway you could lose the sensitivity of the breast. Even the best reconstructive result could be not long lasting. So breast conserving surgery again should be always preferred, also when you consider a nipple sparing mastectomy, also when the result could be very good in the immediate, but the feeling of the breast for the woman is completely different from the natural feeling she could have preserving her own breast.
And also today, if she has to, if she loses her nipple, today there's so many ways to reconstruct the nipple, and there's even tattooing of the areola and nipple for
Yeah.
her to kind of get a complete.
Yeah, we are more and more using the tattooing and the dermopigmentation
Yes,
of the
yes.
areola, and I think this is also very important for the body image of the patient, for her her self-confidence with her
Yes.
own body.
And her emotionally also, you know, she doesn't
Awesome.
get depressed, and I think it's very important. I often find when patients saying that something so small as a scar or a mark on her breast, if she's not been, you know, surgically
Yeah, reconstructed.
properly, it upsets her. She's not able to see herself proper, you know, she doesn't want to look at herself.
Yeah.
So it's very, very important that all these things are kind of taken into consideration. What would you feel, doctor, should be the approach of a patient during decision making? Sometimes a patient takes a decision out of fear or social pressure. The family members are saying just remove your breast because the older family members don't know better. They are 70, 80 years old and they feel that you should just remove your breast, and you. So sometimes she makes a decision out of fear, or sometimes she doesn't need a surgery right now, or she needs a delayed surgery. She needs chemo first, or some other treatment earlier, but she comes from a place of fear where she feels she should not even wait for a week or 2 days. She just remove her breast. Doesn't give her enough time to, you know, absorb what's happening or to be able to discuss and have a second or third opinion. So isn't that
Yeah.
very important for her to take her time?
Yes, first of all, the patient should be conscious that she's the main character in that moment. That
Yes.
she's
The
the
lead
one.
role.
She has the lead role, and then this should also be very clear to the physician and to the doctor, to the surgeon who is going to treat her, because we come from a paternalistic way of thinking in which we think that our preconceived notions and thoughts are what the patient we have in front of us thoughts, but probably most times what matters most to the surgeon is completely different from what matters most to the patient.
Absolutely.
And this is also very relevant in terms of shared decision making. Many times we say that we should go to a shared decision, but in this way, in order to have a real shared decision, we should elicit patient values and preferences, because as you already correctly said, the patient could be not able to say what is most for her. So as patients, as surgeons, we should have the ability and the skill to elicit patient values and preferences, because the women will not be able to tell us all what is relevant for his choice.
So true, especially in a country like us in India, because of the population and the joint family system and the dynamics of the family. We very often find that sometimes the in-laws come with the patient and the patient is not allowed to speak.
Yeah.
And the in-laws are speaking and telling the surgeon what surgery they want her to have and what to do. And she is just quiet and she's not able to discuss anything with her surgeon. So it's very, very important that there is a one-to-one rapport with her surgeon and her alone, where she can talk her fears, she can discuss what she'd like and kind of take things forward.
This is a relevant point. You may know that we usually have a biannual meeting in Italy, the MBN conference.
Yes.
And this year main topic was women empowerment through oncoplastic surgeon.
Very
Really,
relevant.
women could empower themselves, because they should understand that in that specific moment, again, they have the main role, and they should not rely on what other people say, but you, women, are the one you have to take the choices. And you should be driven by the surgeon that should also have the skills to guide you.
Very true, because at the end of the day, it's the woman's body.
Yeah.
And everybody else who's along with her, the parents, in-laws and all, they drift off, and it's her alone dealing with the results, you know, for years to come. And it's very, very important that she and the surgeon are in sync. They work together. There is enough trust with the surgeon that he's going to do the best for her, and she finds the right surgeon who's very, very skilled. And
you use the right word, work together. In fact, we usually use the so-called three-talk model in our shared decision making. This has been described by Glyn Elwyn by the University of Dartmouth in the States, in which we have three main moments in our consultation with the patient. The first one is the team talk, in which we should create a team together with the women we are going to treat, making her understand that we will work together as a team to cure her cancer. Then we have the option talk, in which we should present all the possible options to the patient, and we should make sure that the patient properly understood what we told her. Also, we can use decision aid tools, videos, pictures, photos, and then we should go finally to the decision talk, after eliciting all patient values and preferences, and properly taking into account patient values and preferences. So there are three stages of the talk with the patient.
Yeah, especially in a breast reconstruction or a lumpectomy, if the patient can see few photographs of other patients, what they're going to be looking like. So they feel more assured and they feel more confident.
Yes, there is in Europe, they are running the Cinderella trial. The Cinderella trial is using AI in order to predict the aesthetic outcome of the patient you have in front of you, in order to make as a decision aid tool, and in this way decisions will be made with more consciousness about from the patient herself, because she could see what are realistic expectations about herself.
And what her body would look like post the whole procedure.
And also always take the time to give the time to the patients to take her decision.
Yes.
It's sometimes also not possible for the patient to take the decision in one consultation. So leave her time until we can see in 2 more days or more days. I know there is a lot of time to dedicate, but this is our work.
Yeah, and it's very true, because where breast cancer is concerned, there's no rush. If the patient takes a week later, it doesn't matter. But she should be satisfied. She should be sure that she wants the surgeon. She should be happy. And I always say that there's no harm. Take 2-3 opinions. Take 2 steps back. Decide, is this the right surgeon for you? Do you have a comfort zone with the surgeon? And then kind of proceed.
Yeah.
So, doctor, what are the kind of questions you would advise, say, the Indian woman to ask their surgeon? What are sitting on the other side, what are the intelligent questions that maybe the patient could ask their surgeon?
Well, first of all, I think many times patients could struggle in making question to their doctors. So probably the surgeon should help patients making the right questions, driving into the decision making. Anyway, I think that patients should be able to make the surgeon understand what are their lifestyle, because we can adapt the surgery.
Yes.
Also also for an oncoplastic procedure, we should adapt our choice to that specific patient, to her specific lifestyle. And I'm thinking about also on reconstruction. Kind of reconstruction should be completely focused on the single patient we have in front of us, and so patient
more individualized to her in her conditions.
It should be individualized and tailored on the single patient. And the possibility of tailoring derives from understanding from the part of the surgeon. What kind of patient do you have in front of you? So patient, more than asking, they should talk about herself.
Yes, her lifestyle, what kind of clothes she wears, where would she like the incision,
what is her daily life in terms of hobbies, in terms of work, in terms of commitments, family. This is important in the general, in the final option, in the final decision.
In the final decision. And normally, how many days do the patients stay when they have a reconstruction or oncoplastic surgery in Italy?
How many
in the days in the hospital?
How many days they are
they admitted in the hospital?
If we perform, I can tell you that this is a particular experience I have in my hospital. We are going to publish it. We perform all breast conserving surgery in local regional anesthesia. So no one patient receive general anesthesia, and we dismiss the patient the same night of the operation. So we do a 1-day surgery. When we perform a mastectomy with a reconstruction, usually we have 1 or 2 days of admission, but no more than these. But we should also, this is also relevant for the quality of life.
It's very, very important, because even with Dr. Kopikar, the patient goes home the same evening or the next day.
This is very important.
Sometimes they just have to stay 1 night, because in India, if you have insurance, it's important that they have a 1-night admission.
I know.
But I see patients who come even from big cities like Bombay and Delhi, and they said, for a simple conservation or a lumpectomy, we've been in hospital for 8 or 9 days, and I'm aghast at that, So this is very important, this question that the patient should ask the doctor also. How long will I be admitted? And
Yeah.
she should know and she should be aware and she should be informed that...
Also, what kind of anesthesia will I
yes,
receive? Because
yes.
if it's possible to do also in local-regional anesthesia, why not?
Yes, why
We
not?
do local-regional blocks.
Blocks,
you
yes,
know.
absolutely.
Yeah.
Because she should be informed. I find, especially in India, the patients are not informed. So they just go by, a basic family doctor, refers them to a doctor who's experienced or not, and then they go with that. That is a very big problem in our country. And secondly, the doctors, many doctors in India are not specialized in breast surgery or reconstruction or oncoplasty, so they don't offer it to their patient.
Yeah.
So it's not a win situation for anyone. You know what I mean? The patient also
They don't
loses
even
out.
know that is the
They
chance
don't
of
even,
doing.
yes. On a closing note, is there any advice that you would give the woman from your side, whether it could be about awareness or prevention or about surgery or treatment or anything that you would, the way forward, any single or 2-3 advices that you would give the woman?
Oh, first of all, awareness. So, and
Yes.
you are the master of awareness.
No.
This interview it's very relevant for increasing the awareness
Yes,
of
in the
Indian
country,
women.
yes.
I compared with your colleagues, with my colleagues here in India, and we notice how we treat completely different stage of patients. We mostly have around 80% of T1, T2 patients and small T2, while I saw that you mostly treat large T2 and T3
we
patients.
get patients mostly in stage 3 and 4.
Yeah,
and
yeah,
with,
yeah,
with
yeah.
breast cancer, with early stages, stage 1 and 2 is completely curable.
Yeah,
and
yeah.
stage 3 is controlled, and stage 4, of course, is a different story.
And this is a
But
matter
in
of
our
early-
country, because the women don't come for a prevention checkup, or
Yeah.
she gets a lump, she's so scared of the treatment that she... the treatment is not so harsh anymore. It's very smooth. The chemo is so much smoother. You don't find the woman having nausea. Radiation is smoother.
So patients should be aware of the possibility
Yes,
of breast
possibility,
cancer,
yes.
should undergo screening programs if they are present, should undergo auto-palpation,
Yes,
just also
her own self-examination.
self-examination, and they should be aware that an early diagnosis completely changed the outcome.
Yeah, the whole outcome. It's a question of survival.
Yeah.
It changes the whole survival outcome, with early
Absolutely.
diagnosis.
And they should look for well-trained breast surgeons, because these also make the difference. There is evidence that women treated within a specialized breast unit have better oncological outcomes than patients treated
Definitely.
out of
Because
a
they're
breast
so
unit.
super specialized, and
Yeah.
the doctor's dedicated only to breast, so he or she completely is very well trained in that. And then also there's a holistic approach, there's a support group, there is so much more
Absolutely,
happening
absolutely.
post the treatment, for her to get back into her normal life, back to what she was.
And women should look for you should deserve it. So they should look for dedicated breast cancer
Yeah,
units.
it's extremely important. This is a very, very important message that he has sent today to all of you, that if you have any family member or a friend or anyone battling with breast cancer, make sure they go to a dedicated unit in their city, in their country, maybe out of the country, wherever, and get to a dedicated breast unit. Be comfortable with the doctor. Make sure the doctor and you are in sync with each other, and the doctor and you understand each other, and he's helping you or she's helping you heal back to a normal life that you had before you had the disease. And please remember, mastectomy is not the answer. There is a huge advancement in breast cancer. There's breast conservation, there's breast oncoplasty and reconstruction, making your breast be whole. The incisions are so carefully taken in the areola or under the breast, where the curve is under the breast or under the arm, practically keeping your breast completely clean. And sometimes you're amazed if you see these photographs and you really wonder if the patient has had surgery. If you have a good surgeon, they do a great job, right?
Yeah, this makes the difference,
Yes.
and people must be aware of it.
Yes. Thank you so much for being here with me today.
Thank you. It's
And I
been a
think
pleasure.
the information that you have shared with the community is going to be of great value to the women, especially all over the world and, of course, in India. And thank you very much for accepting to come on this podcast.
My pleasure.
Thank you. Thank you.